Miss Wiggins is Irish. Are you Irish? Yeah, she's Irish also. Little leprechaun's going to be popping out over on Miss Wiggins' planet. Hey, can I just give an update to my Tuesday clinical people that were caring for our vented gentleman? If you're there, that would be, if you're there, he had a successful CPAP trial all day yesterday. All day. Before break, I'll call the unit and find out how he did last night. Just giving you an update. It's kind of incredible. Nobody saw that coming. And Miss Wiggins, I got the roll. You can sit back and enjoy an Irish coffee.
All right, I had texted Miss John that I would take roll, but if you're taking roll, that's fine.
Okay, I got it, girlfriend.
Thank you.
Thank you. Hey, Leslie Loop, what section are you in?
Good morning.
Morning, Miss John.
Good morning. I'm in 317.
317. Okay.
Good morning. Let's start with my apologies first this morning. I'm a little under the weather, but I did not want to skip class. So if I have to take a few additional breaks, please forgive me. If you hear my voice going down, please let me know you can't hear me. I'm glad to have you all in the class today. It's awesome. This lecture may be 2 hours, like it may not. I'm still trying to revise and renew the lecture because it got separated from the first metabolism. So this is Metabolism 2, and this will be the cover of DI and SIADH. So thank you. I believe I'll start sharing my screen. Okay. Okay, we can start from here. This particular slide, I will not go out into YouTube and go through this presentation because that's just there to kind of help you all to remember osmosis and the tonicity, as far as the tonicity of the fluids and the fluid balance of the body. So the osmosis, the fluid shifting, that can help you to get some kind of underlining understanding of it, but it's not information that's going to be testable, and it's information for review. Thank you. So these are post-pituitary issues, and I'm post-pituitary in that you have the anti-diuretic hormone, and when it's imbalanced, you're either going to have a deficiency or you're going to have an excess. So let's look at the excess. If you had an excess of ADH, then you're going to have the syndrome of inappropriate secretions of ADH. So that means you're going to be having way far too much. And as we get through this lecture, you'll find that it will actually hold on to a lot of the fluid. The person will become water toxic. So this is where the water toxification will happen. As far as the deficiency, which is diabetes insipidus, that they're putting out too much fluid. So that means we don't have enough ADH to control it. We have several types of GI. We're not going to focus too much on the different types, but I will mention the types and even some instances where medications will cause that problem. Now, both of these will have issues with osmolality. So, let's see. Let's look at this. And I would love to have some help with this, if possible. The osmolality tells your fluid balance. It allows you to know if you fluid volume overloaded or you fluid volume deficit. So let's look at the normal osmolality. I used the book Beganda and Beganda for the reason we have two books that we use on this level, and they may say something slightly different from one another. So I use the lab book that you use, which is what was used to make the lab sheets. So let's look at our osmolality. So I've already said if it's less than 285, then you're going to have a lot of fluid on the body. That being said, what do you think is going to happen to the cells in this situation?
Gonna swell.
Very good. So it's just like adding water to a balloon. It's going to swell. And eventually, if you add too much water to a balloon, it eventually will burst. So you've lost the nuclei, so therefore you've lost that cell. You've lost that cell's life. Very good, thank you. What is the fluid status? I've already said it, so that's an easy one. What is the fluid status?
Hypotonic.
It's a hypotonic situation, but the fluid status in your patient would be fluid volume overload. They have too much fluid. Okay. So you've already answered the next question. No, you haven't. Okay. So what is the use? What fluid would you use in this patient to kind of get the electrolytes, the osmolality balanced? What fluid do you think you would use on this patient?
A hypertonic.
A hypertonic. Very good. You would use a hypertonic solution. Can you think of any? Come on, Ms. Garrison Group. She told me.
3%. If my people don't say something, Miss Shawn, I'm coming through the Zoom computer with my red pen. I'm coming.
Like a D5 normal?
D5 normal, very good, yay. Hey, I've heard about y'all experience, so you guys can be quiet. All right, so this is true. So let's look at a high osmolality, which is when it's greater than 295. Now, when I usually put this on a test, I'm not going to say 300. 300 is kind of, pushing it. Because if I'm not mistaken, one of your books says 312. All right, so I'll have to go just a wee bit higher. But just know that if it's greater than 295, then you have a high osmolality. And what does that mean?
Dehydration?
Exactly. So one, you had a fluid volume overload, which was a lot of edema. From this point of view, you have too little fluid. Dehydration, awesome. Got that. All right, so what will happen to the cells of a person that's dehydrated?
They'll shrink.
They will shrink. They will shrivel up. And again, now we've killed the cell because it follows up like a piece of paper, just about. And the life is not in it until we get the fluid balanced. So we already said the fluid status of this patient is fluid volume deficit, dehydration. What type of fluid do you think you would use for this patient?
Hypotonic.
Hypotonic, go. Yay. You would use a hypotonic solution. So which solution can you think of that might be hypotonic?
Half normal saline.
Half normal saline, nice. As far as the D5W, when it is on the shelf, it is considered isotonic. However, once it gets into the body, it becomes hypotonic. All right? Now, that's only for this one because, as some of you already know, if in fact it's more than one solution in the bag, more than one product in the bag, it's hypertonic. Like your D5.5 normal saline, your D5 normal saline, you got both glucose and you both got saline in there. So with this patient, I'm going to use the hypotonic. Very good. You all got half the battle done already understanding this lecture. So, of course, if it's normal, what will happen to the cells? The cells will be very happy. They would be very well bathed. What is the fluid status? Well, they're in normal fluid balance. And what type of fluid would we use with this patient? Isotonic. Yeah, thank you. That was Michelle, right? Isotonic. Thank you, Michelle. Very good. Awesome. All right. So now that we went over this little exercise, let's look at the next one. So this is just to bring it home to the visual learner. Okay. We're looking at the cells life with the hypotonic situation. Okay. All right. Isotonic, the cells are happy. Hypertonic, it shrivels up. So you've already covered that. Just wanted to show you a picture to just bring it home. Like I say, because some people are visual, and that'll just help you to get a better clarity of it. Now, we've already talked about 285 to 295. It's always dependent on where you are, the book you use. The reference points may be a little different. So when you begin to work, know the reference point of your facility, which is not a very difficult thing today, because all you have to do is kind of hover over the results, and it's going to give you that reference point. So the great thing about life is that you don't have to memorize everything, but you have to at least kind of have some idea of it. All right? So you notice I have a calculation. So that means we're going to do a calculation. Yes, this calculation will be on the test. All right? When you see sodium, glucose, BUN, you probably need an osmolality. Okay? And there are multiple ways, as I said in the last lecture, that you can assess a fluid volume. But this is actually going through the person's serum, or in some instances the urine, but mostly serum. Okay, so you have this calculation down. So I'm going to give you some numbers. And I want you to calculate it. I want you to bring it to the whole number, okay? You have sodium, it's 300. I'm sorry. Let's go back. Sodium is 150. Your glucose is 70. And your BUN is 23. So that's sodium 150, glucose 70, BUN 23. I'll give you a minute to calculate that, and then please come back to me and somebody can give me the answer.
304.7.
304.7. If you round it to a whole number, what you got?
305.
You have 305. Did anyone have problems with that calculation? Okay. Looking at the 305, that's pretty close to what they call a dehydrated state, your osmolality. So you have a dehydrated situation with this patient. So what kind of fluid are we going to give this patient again?
Hypotonic.
Hypotonic. Very good. Thank you. All right. One more. Your sodium is 130. Your glucose is 76. And your BUN is 2.8.
The BUN is what, I'm sorry?
2.8.
265.2.
Okay, and you round it up, what is it?
265.
Nice. So, this patient is fluid volume overloaded, right? So what type of fluid will we give this patient?
Hypertonic.
Hypertonic, very good. All right. I won't spend much time on this. I believe this was on your handout. Well, we'll spend a little time, but not much. Now, your crystalloids, which is your crystalloids?
Is it isothermic?
Well, all of your crystalloids are isotonic, hypotonic. Your crystalloids are actually the fluid. And the crystalloids actually going to dissolve and break up quickly in the fluid. That's the difference between crystalloids and your colloids. So you notice I have three types of IV fluid. I got your crystalloids, your colloids, and I have the blood and the blood products. Okay? Now, that was just, all of these are considered crystalloids. So you're doing a good job, who's ever talking to me, because I can't see you anymore. But you're doing a great job of the crystalloids of these type of fluids. Your colloids, on the other hand, are your thick fluids like Hispan and stuff, and albumin, mannitol, dextrane. These are called volume expanders, and the reason they use it sometimes because it's so thick that they don't break down into small pieces in the fluid, in the water. So the reason they usually give this is because they want to give a small amount of fluid. All right, like let's see what my reference said. They'll give 250, and it gives you the same effect as 4 liters of crystalloids, just to kind of compare them. There is a downside to it though. It can mess up with the capillaries, and it could even stretch the capillary to a point that the colloids will go through the capillaries, and then you're going to have edema, as a result, taking longer to resolve the problem that's being caused. So crystalloids have their place, but again, it's got an unsafe spot. Now, when I begin to talk, and I hope this showed up in your handout, it's only a way to kind of help you study. I used to pass this out as like a worksheet when we were face to face. So I would pass it out, and you can jot little things on it just so that you can see the difference between diabetes insipidus and the SIADH. I promise I wasn't going to say that word too, the whole sentence too long. So when you look at them, they're opposite. You understand one, you probably will understand the other. Okay? So that can help you to get prepared for study. I'm sure the discussion board for you all to ask questions for test 3 will be getting up there soon. However, someone did email me a question, so feel free to email me. It's just bjean@dcc.edu. Feel free to mail me a question. You can even put the little urgent thing by it so that I recognize it maybe right away. That's a question that you're trying to get answered to study. So you can do that until the discussion board is up there. Thank you. All right, let's look at diabetes insipidus first. So what did I say about diabetes insipidus? Did I say this was a fluid volume deficit or a fluid volume overload?
Deficit.
It's a deficit. So this is where it's going to shrivel up, and this is where we're going to use a half, like half normal saline. This is where we're going to use a hypotonic, because basically, and why I use a hypotonic, just to give you a rationale, I use the hypo with the O tonic because I already have too many solutes. I have a whole lot of solvent, but I have too little solutes. So all it's going to do, if you give another type of fluid, all it's going to do is make the situation worse. Okay? So, you notice I have primary, secondary, nephrogenic, drug related. So, as far as the primary, this is the lack of the ADH secretion from the post-pituitary or some kind of malfunction of your pituitary gland, period. That is the primary. The secondary, on the other hand, is something that you're going to maybe hear about later on, like brain tumors, head traumas. You already heard of IC. I think you've had IC regulation, head trauma, neurosurgeries. All of this can cause diabetes insipidus, especially the neurosurgery, because you're manipulating that area as you as the patient's having surgery, as the surgeon has to um, cut away or pull or tug or whatever. Hypoxic encephalopathy, that can cause a secondary. You even have what they call idiopathic type. And if you remember what they're talking about when they say idiopathic, they are speaking of possible immune, okay? The autoimmune system. All right. Nephrogenic is very easy to figure out. Very easy because it's the kidneys. I mean, there's some malfunctioning going on in the renal area. Now, I'm going to only give you two drugs that can cause diabetes insipidus. One is lithium. The other one is desmocycline. It's DEMECLOCYLINE. Now, this is an antibody. And you're going to hear this again, okay? You will hear it again in this lecture. All right. So they do, in order to determine sometimes the difference between the primary or the neurogenic, because these two, the primary and the secondary, are usually neurogenic issues. And what they do is a water deprivation test. They actually do an ADH stimulation. They give them vasopressin. So the patient will receive the vasopressin, and they're trying to determine the type of DI. So if it's central DI, then the urine is going to increase after the ADH. So if it's the neurogenic type, then you got great. It's going to rise your urine osmolality is going to even rise by 9%. Your nephro, on the other hand, is going to do the opposite. It's going to decrease in the blood, but your urine osmolality for the nephro type, you're going to see kind of a rise in the urine. So you're going to see a rise in the urine in that it's the patient may put out a little more. And we're going to talk about vasopressin a little more because that's the drug of choice for this patient.
You said for primary, what happened?
Okay, the primary and the secondary neurogenic. So your DI, you're going to have a rise in the urine osmolality. And scratch what I said about the nephro. Let's look at this one so it won't get confusing to you. The nephrogenic GI, there will be no to minimal response to the ADH. But whenever you have any type of DI, you're going to have an increase in urine. Okay. Hope I made it clear for you. I'm sorry if I confused. I thought I had one before this. Oh, it's after. Okay. Let's go back up. So, I'll put it in here backwards. Here we go. Let's look at your clinical manifestation. This is a copious amount of urine to put out in a 24-hour period. So, you know, definitely you're going to have severe dehydration going on. Now, a specific gravity is actually a spin or something like that, a test that you can tell how diluted the urine is or how concentrated the urine is. In this situation, what would you expect the urine to be?
Diluted, right?
Very, very diluted, right? I just wanted to get y'all's take on it. All right. The manifestation, so it's related to dehydration. So what happens if you have cardiovascular dehydration? What would happen to your cardiovascular system? Look like we talked about this recently.
Decreased cardiac output.
So you're going to have, let's think about your hemodynamics. What's going to happen with your blood pressure?
It's going to decrease.
Okay. And what about your heart rate?
Increase.
Yes. And how your pulse will be feeling? Your pulse.
Your pulse going to be increased.
Think about it having less fluid.
Weak.
There you go. If you touch them, the pulse might be a little weaker. All right. And of course, there's hemoconcentration going on here. As far as your skin, it's dry, poor turgor. We already said what the urine is going to do. I believe in your Baganda and Baganda, the specific gravity is between 1.005 to maybe a little bit like 1.30. 1.030 is on a concentrated end of things. So, of course, when you're putting a copious amount of fluid like that, you're going to have a low specific gravity, less than 1.005. So you're going to have less than 1.005. Water is 1.000. So that's pretty close. So when I think about the neurologic effects of it, I think about thirst. I think about decreased cognition. I think about irritability. They become lethargic, and you can even go into a coma. Now you recall, I believe, yes it is. The interrelated with this one is cognition. So I'm going to kind of, introduce cognition a little bit right now. When your sodium is high or low, but when your sodium is high, the cognition would change. The patient would maybe even become agitated, have seizures, those type of things going on. Oh, and like I said, they may have the coma to the death. So that's it with that one. Oh shoot, I didn't like that. That was just a breeze. I'm sorry. I didn't realize my computer was that sensitive. Okay, so looking at serum osmolality, help me to remember what's a norm.
85 between 5 to 295.
Thank you. The next one, I'm going to take it because I don't remember saying this to you before. So your urine osmolality is 50 to 1200 milliosmol per kilogram. So you notice this long, it's just like a big difference. A lot of that's dependent on, did you drink a lot of fluid? What you drank? Did you drink coffee? Did you drink water? So the norm has a kind of a big gap between it. But the norm is 50 to 1200. Somebody give me a normal sodium, please.
135 to 145.
Appreciate you. Thank you. What about the BUN?
10 to 20.
Boom. Wow. Awesome. So, see? What you needed me for. You got this. All right. So, I did say sodium can lead to cognitive changes. All right.
So is there certain assessment findings specifically for DI for those that you just named?
I'm sorry. I didn't understand the question.
Are there certain assessment findings for like BUN and the sodium?
Well, the BUN, I'm glad you asked that. The BUN can be normal to elevated. It just depends on the situation. As far as the sodium, what do you think?
Elevate.
There you go. Put some good critical thinking there. It's elevated, but thank you for bringing that up because I actually had it written down and I didn't see it, so forgive me. All right. So I think we said this ad nauseum, but let's say it again. We're going to have to do a volume replacement. What kind of fluid will we use?
Hypotonic.
Hypotonic. So I'm going to use half normal saline. Now, this is what I'm going to do with it, especially if this person is putting out 4 to 30 liters of fluid within a 24-hour period. Hopefully it doesn't last that long. But I'm going to replace that fluid. Somebody trying to drink 3 liters an hour sometimes will be just not doable. Some people, I guess they can do it, but these people will need to replace the fluid. So if my patient's urine is 1 liter, then what I'm going to do is give them 1 liter a half normal saline on the next hour. Now, if it's like 500 or 600, they may be able to drink it, but if they can't, we got to make sure this fluid is replaced or cells gonna die, and we don't want that to happen. So thank you. Let's look at the what we're going to give, especially for the central, well, the primary and the secondary. It's called desmopressin. And it's given a lot of times nasally. Vasopressin could be given in a drip if it's really that critical. We usually say vasopressin for other issues, but it could be used here. It's usually dependent on the situation. And it's done on a PRN basis, meaning if my patient put out a liter of fluid, then I will need to hurry up and give them their dose of DD AVP, which is the one for the nose, their vasopressin, immediately because I'm putting out too much fluid. And what the desmopressin is going to do is it's going to decrease that excessive urine output. That's the reason I'm giving this medication. So with my nephrogenic, it has like this paradoxical almost effect with the thiazide diuretics. You say, okay, they're urinating a lot, and you're going to give them a diuretic. In this situation, yes, because I want to slow down the rate of allowing the kidneys to reabsorb, the rate of the GFR, so that the kidneys can reabsorb some of the water. And they also will definitely give them things like low sodium dye because they already overconcentrate. And all of this will help bring down the urine. Okay? Thank you. Any questions before I move to the next slide? Any questions about anything that I've already talked about? Okay, thank you. So what we want to do here is we want to do early detection of dehydration. The patient, as they're putting out that much urine, and you see that happen. Your patient just came from surgery and had something done in the head, craniotomy. So you're going to keep strict INOs, very strict INOs, because you're going to pay attention. If this patient is putting out a significant amount of urine, what I call significant amount is, let's see, I say we started at 4 liters, right? So I say, like, if they're putting out like 600, 700, then 800, you notice we're climbing. We're putting out a lot of copious amount of urine for no reason. You need to alert someone when you see a trend, even a trend of 2 hours. You need to alert. That way you can catch this patient before they get into this severe dehydrated state. They don't have to be in that state, but you as a prudent and a great nurse will try and catch that before it happens. All right? To this patient, you want to provide fluids at least every 4 hours. Now, you're usually given a replacement when it's extremely high, but you want to make sure that this patient is getting the fluid they need. Now, if your doctor should choose to use D5W, you're going to have to really pay attention to the glucose because this patient is going to be receiving copious amount of fluid. No, I can't identify at one time what the physician or why they ordered it. Excuse me. Okay, so let's say at INO, look at your urine specific gravity. You're going to monitor this person for hypothermia because as they dehydrate, sometimes the temperature go up. Okay? As far as your patient teaching. You have, if a patient gains 2 or more pounds, they really should inform their healthcare provider, and they may already have an order once they leave. These are people that's leaving the facility. What may be happening if they have an order of desmopressin. Mike, someone's mic is open and they're trying to have a private conversation, so thank you. All right, so they need to report this to someone. If they're in the hospital, you need to report it to someone. All right. So what I was saying about desmopressin can take you from one extreme to the next, meaning your patient can go out of DI into SIADH. If they start taking the oral desmopressin, then it can cause ulcers, different things like that in the mouth. So you want to make sure that that patient, drink enough fluid in order to take that pill down. If they're doing the inhalation type, they may start getting tightness in the chest. So these are some common situations that you might have to either monitor if they're still there or teach them about it. Now, whenever you give oral desmopressin, always make sure that it's got its own dose. I think its dose might be about 10, but I can't remember the exact dose. Thought I had it written. Yes, here it is. Your IV form is 10 times more than your oral form. So you make sure that you have the right route and medication when you give it, okay? Because sometimes it can get a little confusing when they're ordered. They're saying it's best to do it oral or IV if in fact they cannot take it through the nerves and it causes tightness in the chest. You don't want your patient uncomfortable. Okay. Okay, we already talked about the vasopressin, and we already talked about that it could cause a water intoxication, which is SIADH. We already mentioned that the patients need to weigh every day. Didn't say the same scale, the same clothes, because you already knew that. If this patient becomes confused or get a headache, they need to probably return to the ED. So if they have a caregiver, you need to teach the caregiver this as well. If they get that sudden headache and that persistent and sudden confusion and persistent headache, then what might be they might be going into water intoxication, and you're to tell the caregiver or the patient to call 911 and go to the ED. Now, there is such a thing as permanent DI. If someone is diagnosed with permanent DI, then you let them know that they need to take their desmopressin. If their urine started to increase, if they get the polyuria and the polydysmia, they need to take another dose of desmopressin. Okay? And a good thing for anybody that has a unique disorder, that medical ID bracelet is a great tool. And as I said about the desmopressin, sending you into water intoxication, which is SIADH, This is a good segue to that. All right. Any questions about DI? All right. Please return at 9:30 and we'll start again. Thank you. Okay, let's finish the second half. Now, water intoxication is just as bad. There are a number of reasons why someone will have additional high levels of ADH. One being a secreting tumor. Others are like your central nervous system disorders, your head surgeries, neurosurgeries, some infections. The neurosurgery is the only thing I think might have a little bit in common with the eye, and the fact that it's still a manipulation and it can go either way. Once you go into somebody's head doing like a craniotomy or something of that nature. All right. You got multiple drugs that induce water intoxication. As you see them all, well, that's not all of them, but that's a real large number of them. And even PEEP in some instances can cause SIADH. PEEP on your mechanical ventilator, because what it does with the extra pressure, it stimulates the renin-angiotensin system, which causes it to hold on to fluid. So that's the reason for the PEEP. I had to look that up several years ago because of the, PEEP? Wasn't absolutely sure. So many years ago, I had to school myself on that. All right. And let's see, try that again. All right. I thought it was giving up on me as far as advancing. So your earliest manifestation, and I saw it the other day, and I didn't write it down. But what's unique about this particular one is that they have fluid retention, but no, without the edema. And I believe the reason that I remember it is because it's just water, not necessarily the sodium that's causing a problem, because the sodium and water together is when you have pitting edema. So, UGI disturbances, nausea, vomiting, anorexia. In this situation, your pulses are going to be bounding because you have a lot of fluid in the intravascular. Okay. So we're looking at the same labs, but from the opposite end of the spectrum. So I gave you the labs earlier. I gave you the norms. So the serum osmolality for this patient would be what? On the high side or the low side?
Will it be less than 285?
Yes, it will. So, because we're holding on to excessive fluid. Now, the urine osmolality, on the other hand, it will be increased because the urine is concentrated. You're going to have like a specific gravity of usually greater than 1.030. It might be equal to, I can't remember, but I know greater than for sure. All right? 1.030. That means the urine is super concentrated. Now the sodium, of course, we know the sodium is also going to be lower. But here is where we really got to get concerned. When you see numbers like 110, 115, 120. Those are not good numbers since we said the lower side of sodium is 135. And you can have all kind of critical neurological changes in a patient. This patient too can have seizures. So it's important that you monitor and maintain the patient's fluid status to be a norm. Your BUN may be on the low side in this situation because of overhydration and hemodilution. One of the things you want to pay attention to with this one as well is the possibility of hypokalemia. And you know what happens with that? You'll wind up with all kind of cardiac dysrhythmias that you really need to be careful of because a lot of those will lead into a heart attack. Okay? A cardiac arrest, I'm sorry. All right. Now, here's where we're going to treat this patient a little bit different. This patient, on the other hand, is going to have what they call fluid restriction. So they can have a liter of fluid, up to a liter of fluid a day. It depends on the healthcare provider, and it depends on the patient's lab values, what's going on with them. So 500 to 1,000 milliliters a day. That's the kind they usually put them on. From pharmacology or previous levels, let's see if you remember this. So 1 liter of fluid is equal to how many kilograms of weight?
0.5.
That was a good guess.
One.
It's 101, 1-to-1. So remember I said kilograms. The person who was talking probably was thinking pounds. But I said kilograms, so it's 1 kilogram of weight. If they gain 1 kilogram of weight, then they're retaining 1 liter of fluid. So 1 kilogram of weight is equal to 1 liter of. All right. Now, some of you may have seen 3% saline. You've heard of it because Ms. Wiggins talked about it, I believe, in IC regulation. However, 3% saline, we give it slow in this situation unless a healthcare provider does otherwise. There is a practice now where they'll actually do a fluid bolus of saline, which is rare, but it can happen. So everything is not black and white, but for the sake of this, they really recommend that you do it slowly. Usually like 30 milliliters an hour, okay? When I say treat the cause, what caused it? Was it the medications? If this is a medication, side effect, then we're going to remove the patient from the medication. As far as the oak cells, you can do as well as you can with that, but you want to treat the cause in order to alleviate the patient of this excessive fluid. Now, Lasix is making sense here because you want to remove fluid. I thought I changed that. I don't know where it came from. Okay, I'll clear something up in a minute. The desmocycline, if you remember earlier, we said it caused a nephrogenic DI early. And this word should be nephrogenic, not neurogenic. nephrogenic. And when you use those two medications, the Lasix is going to remove the fluid, but the desmoprocycline is going to cause a DI. They want this to happen in this situation so that they can relieve a lot of the fluid off the patient. Okay? We don't want the patient to stay in fluid volume overload because in some instances you can send them into congestive heart failure with that much fluid on board. There is a medication that's called tolvaptan, Tolvaptan, and it's only administered in the hospital because what it's doing, it's bringing up the sodium level, and you don't want to bring the sodium level up too quickly. So you have to constantly monitor this patient. Now the desmoprocycline, I think I told you it was an antibiotic, but they will use this, what they call off-label, because there's no proof that this really works, but I have heard that people do that. So it's more off-label use in that aspect. All right. Any questions? So you definitely want early detection. You want to catch it before the patient get this issue. Trying to find if I had anything else to say about this. What fluids would you use in this situation? What fluids would you use?
Hypertonic.
Hypertonic, because I just finished talking about the 3% saline. Now, your patient teaching is similar. You want them to weigh themselves daily. You want them to report if they have an increase in the weight. This particular one, I don't recall having any at home. I think they really get this resolved before they go home. We've already talked about side effects of the medication. So those are things that you all going to want to do with your patient. Okay? Any questions about either one? So we're gonna do, I think this time, 2 case studies and a few questions and we'll be done. All right? So let's read this one. All right, so I already said that the patient has diabetes insipidus. So we're going to ask a few questions about it now. What physical and laboratory findings, and I think you have the question, led to the diagnosis of diabetes insipidus? So what gave you a hint? That's what this patient had. What gave you that cue that this patient may have DI?
When he started drinking nonstop.
When he started drinking nonstop, very good.
He was dehydrated. Excessive urination.
Excessive urination or dehydration, very good. All right.
What about the head trauma?
There you go, the head trauma. Because that's what brought it on for this particular patient. Got a little cerebral hemorrhage going on, but it's a head trauma. So those are many of your cues that would let you know, this might be DI. And you can anticipate, okay, which direction the healthcare provider will go. All right? Very good. If you got a number 2 on your paper, omit that. I didn't really want to go into details on, how you test to make sure that the patient is DI and what type. That's a need to know, so I'm not talking about it. So the next one is identify potential priority problems for this patient based on the data that you're looking at.
Dehydration.
Dehydration.
Other level light imbalances, maybe.
Yes, I heard another voice though. What did you say?
The decreased level of consciousness.
The decreased level of consciousness, right? You're doing great. And this patient can go into shock as well. Okay? Because of the excessive fluid loss. They can go into hemovolemic shock. All right? Very good. Identify some nursing measures that would assist the patient to maintain adequate fluid balance. State the rationale of the measures, if you can.
Intake and output.
You must do I and O. Very good. Rehydrate the patient. You're going to get this patient hydrated, right?
Mm-hmm.
If in fact he had been in the hospital already, then you would replace the amount of urine that the patient is putting out with a hypotonic solution. You're going to weigh this patient daily. You're going to try and encourage the patient to drink oral fluids if they can. If they're not able, then you're going to replace with the IV solutions. So you're going to also make sure you have IV lines. You're going to make sure that the patient does not get a complication. You also want to make sure that the patient does not have a side effect to their desmopressin. And the safety concern here is going from one extreme to the other. So you would give the fluid return, the fluid challenge. You would also give this patient their dose of vasopressin. If the fluid continues, and you will replace the fluid. I think that's all I wanted to say about that. All right. This is usually a classroom activity, but I'm not going to get you all to do it. But I was lucky enough to glance over, because I had been doing it, and I was lucky enough to glance over somebody's shoulder when they were doing a HESI. You all do CAPA now. And oddly enough, they had something similar to this. So it's very important to do strict I and O on your patients. Always. But in your critical care, it's very critical that you do it because this is how the physician is ordering medications. This is how the physicians are actually treating the patient. So if you don't keep up with it well, you may cause harm in the care of the patient or the treatment of the patient. I thought I had an answer up there. No, I don't. Must have taken an answer out because I have it on my paper. So by the time you calculate it, you come up with a difference of 3,000. Meaning you got 3,000 milliliters that remained in this patient's body. All right? Because what I came up with, when I calculated the intake, I had 8,550. When I calculated the output, I had 5,550. So this patient is now a little fluid volume overloaded, right? So we might be having some concerns about patient going into water intoxication. May not be, but we're concerned. So right now we've taken a patient that was in a fluid volume deficit into a fluid volume overload. Okay. All right. Let's look at the next one. This is the same guy, but the same patient. However, he I think he was discharged and he received medication dosing. I actually put it a little higher on purpose. I'm sure I'm sure they wouldn't send him on medication that high. But I want you to look at this, and I'm going to ask you similar questions like I asked on the DI. So, what physical, I don't think I have labs in here. Yeah, I do. Okay, what physical and laboratory findings led us to diagnose this patient as SIADH?
Gaining 3 pounds in 24 hours.
Right. That is a lot of weight. And you remember I told you to teach them if they get this persistent headache? I didn't say the patient was confused, but that headache, that persistent headache, and that 3-pound weight gain, that's a lot of weight within a 24-hour period. So, what lab are you looking at that might alert you that that patient might be holding on to fluid?
Sodium.
The sodium is very, very low. Thank you. So, since the sodium is so low, and we also, when we assess, which I didn't say that would be a part of it, but when you hear a lot of crackles in a lung, you probably have a lot of fluid on board. Okay? I didn't put in the fact that he had non-pitting edema, but if I would have put it in there, that would be another point to say, that might be SIADH. Okay? All right. So the patient is a little hyponatremic due to excuse me, hemodilution. But we have to do something about that sodium. Now, I haven't mentioned it all day, but DI and SIADH are both life-threatening complications. All right? They are life-threatening. So we need to take care of it. We need to take care of it quickly. We need to monitor, do strict INO, and follow your hospital protocols. All right. This patient could literally have a seizure. Okay. So I think this is if the care plan, because okay, we've already used 3%, and when I wanted the safety concerns of 3%, I don't want to send the sodium up too quickly. All right. When you say identify nurses measures, you got to keep this patient on, excuse me, you got to keep this patient on fluid restriction. You remember at the beginning I said 500 to 1 liter? This patient is on fluid restriction. I think I only have about 3 practice questions and then we'll be done. Have any answers for me? Okay, this is to select all that apply.
A, B, C.
Good. Stop right there. The nasal vasopressin is for the DI. And this patient is on fluid restriction. Okay? So good answer. I'm sorry, I didn't bold my select all that apply. You probably didn't see it.
Excuse me, what do you mean by padding? Like the tuck space?
No, patient can have seizures.
Oh, okay.
So provide padding, I guess, to the bed rails would have made it a better answer. So you want to at least make sure the patient does not injure themselves. Because this sodium is 115, and this patient can definitely have seizures. Thanks for asking that. I'm glad you brought that up.
Miss Shawn,
Yes.
hey, this is Wendy Garrettson.
Yes, ma'am.
Can I tell the students something that I didn't know for a long time?
Oh, yeah, because we're going to
vasopressin is ADH, right?
You're right. We're going to finish early, so yeah, you got time. So go for it.
So vasopressin is your ADH, anti-diurese. I will not diurese. I will not diurese. The last thing you want to give somebody that's holding on to fluid is more ADH. And vasopressin is ADH. I didn't know if you knew that, but I didn't know it for the longest time, and I just kind of learned that not that long ago. That's it.
I think I had to learn that because I was a neuro nurse. Yes, I was neuro ICU. So neuro and MICU. So that's probably why I would get a hold of it, because you got a lot of things with cardiac going. I usually tell my students, hey, I'm not cardiac woman, I don't have that. And I didn't know if you want to share your story, because I remember you had a story. If you want to, good. If you don't, that's fine. Because I remember you had a story in the past about that little sodium.
My mom,
if you want to.
I would love to say that real quick.
Sure.
My 82-year-old mom presented with altered mentation. We were thinking it was because she was taking Darvocet for her osteoarthritic hip. However, that was not the case. So I called my Uncle Leo, who was internal medicine way back in the day, and he said, It's her electrolytes. Get her to the emergency room. We went to the ER and my mother's sodium was 114. The ER docs, intensive care docs, everyone said, we cannot believe your mother's not dead, comatose, or seizing. She was treated very, very carefully with 3% saline. It was given in very small amounts and very slowly. And her sodium level did come back up as it was supposed to. But honestly, my mother was never neurologically the same ever again. The 2-week stay in ICU, she became very debilitated. My mom never walked again. She walked some in rehab, but it was too much for her. And she told us in her a little confused state, I'm quitting that job. And she was in a wheelchair for the remaining 7 years of her life. And nurses, when you've got a patient for a 2-week stay in ICU and you have the opportunity to take that indwelling urinary catheter out, take it out. Because my mother developed a neurogenic bladder and was never able to empty her bladder again without an indwelling catheter. For the remainder of her life, she had an indwelling catheter. So just remember that. And what contributed to my mother's low sodium? It was the hydrochlorothiazide that she was on for hypertension and the Celebrex that she was taking for her osteoarthritic hip. Both sodium dumping meds. How you like that? Low sodium ain't nothing to play around with. So be careful with your older folks that are drinking all that water. That's not good. If that's happening to your grandparents or something, be very mindful of that. Thanks, Ms. Shawn. Thank you. Thank you very much for letting me say that.
Thank you for sharing that, because you did bring a lot home, and for some of the students, I'm sure, because sometimes when you can put a picture with it, it'll give it a little extra twist. And the protocol, I don't know if the protocol is like this at all facilities, but the protocol at the facility that I bring the students, which is UMCNO TICU, you got to have that Foley out. You have to have a good reason why a patient will have a urethral catheter. I don't care if they're on a ventilator or whatever, they go to the condom care as soon as possible. Mainly for infection, but again, just what Ms. Garrison just said. It can cause all kind of complications that we don't realize it's a problem. Yes, it's it's convenient for us as nurses, but it's not good for the patient. And as nurses, we take care of patients. It's not about us, it's about them. Okay. So, all right, that's the answers. Your DI, read the question. This is a single answer. Yes, you will at some point.
See?
Yes. It was kind of set up. It was set up push. Because you remember when I said diabetes insipidus, and I want you all to remember, with the diabetes insipidus, they had a urine of 700. What should the nurse do? We're going to replace the hypotonic solution. Now, I didn't totally rule out notify the healthcare provider because I didn't say where the patient was. More than likely, this patient is in critical care. We're going to have some form of standing order for that patient. The doctors will already have ordered to replace that fluid. Okay? So just remember those things, and C is correct. So there's really nothing to suggest since I'm saying it is a DI patient. But if it was another type of patient, yes. Well, thank you for your time and attention. I usually talk pretty fast, and I separated this from another one, so I guess I have to work on getting some extra time. But you all take care, and thank you so much for coming to lecture.
Thank you, Miss Shawn. The roll is done.
Thank you.
Ms.
And
Garrettson,
anybody have questions, I'm answering.
I have a question for Ms. Garrettson.
Yes, Liz.
Did you call EJ this
Yes,
morning?
I did. Yes, I did. This is what happened. Miss Shawn, thank you for letting me give her this update on her 83-year-old care plan patient. Yesterday, the nurse had to put the patient back on SIMB at 6 p.m. because he was pooping out a little bit. But they put him back on a CPAP trial at 9 o'clock this morning. Hemodynamically looking good. So today's another day, but he lasted all day till about 6 p.m.
That's
Put that
awesome.
put that in your evaluation column.
Well, thank you for updating me.
You're welcome. You're welcome.
All right, thanks.
Bye, guys. Wear green or you're gonna get pinched.
Rats, I don't have any green on.
Ms.
Miss
Shawn,
Shawn.
I have a question.
Yes,
Will the
ma'am.
lecture be posted?
Not this one.
Okay,
I didn't record.
okay.
All right.
Ms.
And
Johnson,
yes, later on, because I'm going to be doing this lecture tomorrow, I just decided not to record today because I was kind of under the weather and I wasn't sure how I was going to present. Okay. Thank you.